Good afternoon, everyone. In the interest of starting on time so we can end on time, we'll begin. My name is Chris Wolfworth. I'm the director of the Montgomery Fellows Program here at Dartmouth College, and it is my very great pleasure to welcome you here this afternoon to our current Montgomery Fellows presentation presented by Professor Sir Malcolm Grant. Those of you who are coming in, there are tons of seats left in the auditorium, especially down here in front. Everyone seems so far away, so please come sit by me. Great. Well, since 1977, the Montgomery Fellows Program at Dartmouth has brought a total of 243 distinguished individuals to work, live, and learn with us here on the Hanover Plain. Ranging from astronauts to zoologists, titans of business and blockbuster performers, former presidents and Nobel Prize winners, each fellow, in his or her own way, has enriched the Dartmouth experience with their talent and presence. The Montgomery program is the brainchild of Kenneth Montgomery, Dartmouth class of 1925, and his very vivacious wife, Harl. It was designed to give students up-close and personal access to a variety of creative individuals, to provide the opportunity for students to see how a life lived with meaning and integrity manifests itself in individuals of diverse talents. Kenneth and Harl Montgomery saw this kind of access as the perfect complement to the Dartmouth education, and we are grateful to their generosity, which outlives them and which continues to reap benefits for all of us lucky enough to live, work, and learn here. We have recently been graced with a number of visual artists as Montgomery Fellows, individuals whose creativity is perhaps easily recognized. But creativity and inspiration have their place in all fields of human endeavor, and so it gives me great pleasure to profile for you today a different kind of creativity, an individual who uses his talents in the service of the common good. Public service often doesn't receive the attention it deserves, or at least not the good kind of attention that it deserves. In the United States, and particularly now at election time, we are bombarded with negative ads and public squabbling, which leaves us all feeling ill-served. Our very visible political class ill represents the legions of individuals whose work allows our societies to function at all. These behind-the-scenes public servants struggle to reconcile individual interests with the public good every day. And here, perhaps more than any other field of endeavor, creativity is needed to overcome the impasses created by the tension between public and private interest. Professor Sir Malcolm Grant has dedicated the better part of his professional life to public service. He earned bachelor's, master's, and doctoral degrees in law in his native New Zealand at the University of Otago. He relocated to the United Kingdom to teach at the University of Southampton and later became professor of law at University College London. He served for a time as professor and head of Department of Land Economy at the University of Cambridge and a fellow of Clare College. While at Cambridge, he was appointed Pro-Vice Chancellor, and then in 2003, he returned to University College London as its 9th provost and president, where he served for 10 years. During that time, UCL distinguished itself as one of the world's leading research universities, consistently rating in the top 20 globally. As head of UCL, Professor Sir Malcolm Grant reintroduced the concept of philanthropy to the funding structure of the institution and oversaw its modernization and reform during one of the most turbulent periods in UK academic history, weathering no small amount of controversy in the process. A specialist in planning, environmental, and property law, his academic career has given him a grounding in all the significant issues surrounding the management of public resources and private interests. He is the author of several books and articles and was editor of the Encyclopaedia of Planning, Law, and Practice for 22 years, where he remains a consulting editor. In recognition of his scholarly work, he was elected honorary member of both the Royal Town Planning Institute and the Royal Institute of Chartered Surveyors. His scholarly work has been complemented by significant contributions to public service in a practical sense, both in the UK and internationally. He was for 6 years the chairman of the Local Government Commission for England, and for 5 years chairman of the UK government's Agriculture and Environmental Biotechnology Commission. He has chaired the Russell Group of the leading UK research universities and has been a member of the board of directors of the League of European Research Universities, as well as serving on boards of the Higher Education Funding Council in England, the University Grants Committee of Hong Kong, and the International Council on Global Competitiveness of Russian Universities. He is also president of the Council for At-Risk Academics, an organization that provides refuge and support for academic colleagues at risk of or suffering from discrimination, persecution, violence, all on account of their race, religion, nationality, membership of a particular social group, or political opinion. In short, he has worked for the promotion of sound public and education policies at the local, the national, and the international level. His services to planning and local government earned him a Commander of the Order of the British Empire in 2003, and he was knighted in the 2013 Queen's Birthday Honors for his services to higher education. In 2011, Sir Malcolm received perhaps his most challenging public service assignment yet. He was appointed the inaugural chairman of NHS England, a new independent body appointed by Parliament to manage the National Health Service in England, the largest and oldest single-payer healthcare system in the world. NHS England commissions healthcare for a population of 55 million people and holds an annual budget in excess of 110 billion pounds, over 175 billion US dollars. The goal of NHS England is to deliver significant long-term improvements in health outcomes and quality of healthcare in England. His charge in brief has been to oversee the modernization of the NHS, a reform process the most significant since the NHS came into effect in 1948. Sir Malcolm Grant has had a unique and challenging career reforming two of the most difficult bureaucracies ever, education and healthcare, which in England are essentially public enterprises. I've heard it said that reforming entrenched bureaucracies is a lot like moving a graveyard. It's a dirty business, and you're not going to get any help from the people on the inside. Perseverance, then, is also a necessary ingredient to a successful career in public service, and it can take decades and perhaps lifetimes to achieve real change. We are fortunate that our guest today has demonstrated perseverance, as we are committing him to a punishing schedule. While at Dartmouth, he has visited with students in the Dickey Center for International Understanding's Great Issue Scholars Program and student residents of the new Global Village Living Learning Community. He has discussed the challenges of climate change on healthcare with undergraduates and graduate students whose own research interests intersect these issues. He will visit Professor Denise Anthony's sociology class, Global Health Systems, meet with health and pre-health students of the Nathan Smith Society, and present at the Rockefeller Center's Rocky Leadership Fellows program. At the Tech School of Business, he will join business students for a discussion of how culture enhances or impedes institutional change. And these are just the visits with students. In between, he will meet with faculty, staff, and students engaged in all aspects of healthcare delivery and talk shop with those of us interested in higher education management. It is a full schedule. In the meantime, this week, NHS England is releasing its much-anticipated 5-year forward view, which will lay out the broad strokes of the most significant reform for the NHS since its creation. It's a big week to be away, which makes us all the more fortunate to have a strategic leader of that process here today to share with us this most significant of public service challenges, the challenge of providing healthcare for an entire population. Please join me in warmly welcoming Professor Sir Malcolm Grant.
Well, thank you so much, Chris, for that very generous introduction. And can I just say, first of all, how delighted I am to be here in Dartmouth, not just because I'm escaping from London and the National Health Service, but because I know here there is a real passion about the topic that I'm about to address you on. But before I kick off, I want also to extend my thanks to Kenneth and Hal Montgomery for their exceptional generosity in creating this fellowship and creating an opportunity for me to come here. And also to thank the trustees for their choice. I'm really honoured and humbled by the opportunity. I'd like also to pay tribute to Al Mully, who has spoken to me many times in London about the passions that we share, about how do we develop healthcare systems that are fit for the populations that we serve. And that, I guess, is really my theme for this evening. Because, let me say right away, I'm utterly committed to the idea that civilized nations have a duty to their citizens, and that it's a duty to ensure that there is comprehensive healthcare available to all, either free or at reasonable cost. No citizen, I believe, should be required to go into bankruptcy in order to fund healthcare costs. So the question arises, is that actually possible? And what message do we, from the UK and the US, send to those nations who are rapidly growing economically and who have an opportunity to develop a healthcare system for populations which at the moment are not able to access such a model? So I thought it might be useful to introduce very quickly something of the concept and the conception of the National Health Service. And that first line appeared in the rhetoric of Nye Bevan, the great politician who introduced it to the House of Commons, in place of fear. Remember, in 1948, a nation that was daunted and damaged and bruised from a grueling war, and to whom an incoming socialist government felt there was a moral obligation to provide comprehensive healthcare, comprehensive housing, comprehensive social security, the laying of the foundation stones of a modern welfare state, of which comprehensive healthcare remains at the centre. So the concept of it were that it would be universal and free healthcare for all at the point of need and without charge, a single service covering the whole country for the health of the total population, and that it would be totally borne from tax. As many are aware, there are many models of healthcare provision across the world, but the two fundamental ones are the so-called Beveridge model. By the way, Beveridge was a conservative who plotted the future of the NHS in 1942. Nye Bevan was the socialist who introduced it in 1948. So political honours in the 1940s are roughly equal, which is important to remember in 2015 as a general election approaches. Count Otto von Bismarck, on the other hand, was German, as the name suggests, but it was the Chancellor's vision to have a healthcare system not totally tax-borne, but one that was backed by an insurance, and in which the citizen would often bear the upfront out-of-pocket costs, but they would be reimbursed either by the state or by an insurance model supported by the state. From those two foundation stones emerge a wide variety of different healthcare systems across the world. Certainly in terms of numbers, Bismarck trumps Beveridge across the world. What we need to ask ourselves is that true also of performance? So in a sense, the 1948 model gave us a nationalised service industry. And one thing the British are not very good at is running nationalised industries. And one of the indicators of attention that remains with us is in that next heading, the 1948 Tredegar bedpan. Let me explain. Everybody knows what a bedpan is. But as the Nye Bevan, the minister responsible for introducing the bill, explained, his idea of accountability was that when a bedpan was dropped in the wards of Tredegar Hospital, which was in his hometown, the sound of it would resonate down the corridors of Whitehall. In other words, he, the minister, was responsible for the dropped bedpan. Now, it's a model of accountability which was ridiculous in 1948 and is completely ridiculous in 2015. But it's a tension that keeps re-emerging in a National Health Service. And in a culture within Britain that's very keen on the idea of centralisation, but very keen on the idea of centralisation of process rather than centralisation of outcomes. Now, that's an important distinction, and it's one which I'm going to come back to time and time again tonight because it helps to explain why I'm in the role that I'm in. That last point on that slide is also critically important because it places the National Health Service within an ideological debate, and at the heart of that is a debate about the role of markets in providing healthcare. It's largely an uninformed debate, but the rhetoric of it resonates down the corridors of Whitehall every bit as much as the Tredegar bedpan. And as we come to the 2015 general election, we can expect that to be even more accentuated. Well, I'm going to show a few slides now which examine on a comparative basis the funding and the outcomes on several measures of the NHS. And then I'm going to try and turn to grapple with a bit more of the difficult reality. But let's look at the funding. Health expenditure as a percentage of GDP has the United Kingdom a little above the OECD mean, which is the red bar in the middle. Within each of those bars, there are two colours. The lower colour, the dark blue, is the tax-borne contribution to healthcare costs. And the higher colour, the light blue, is the private contribution to healthcare costs. And you can see that no nation is 100% tax-borne. In the United Kingdom, the proportion of tax-borne is about 8.2% of GDP, and the total is about 9.4% of GDP. The one outlier on the left-hand side, I won't say anything more, but the thing I would actually point out, which is often forgotten, look at the tax-borne proportion of that. It's about the same as the UK. So the American taxpayer is paying the same proportion of GDP towards healthcare costs as they are in the UK. The big difference is in the percentage of private contribution. There are two ways of commonly assessing healthcare costs. The other one is per capita. And this chart, in which the figures are normalised for differences in cost of living, showed that the UK, New Zealand and Australia are towards the bottom of the comparative table at about $3,000 to $3,500 per capita, and the US is at $8,223. The other nations ranging up towards there are largely Bismarck-style healthcare systems. So there's an issue about cost. Let's then compare cost with other indicators. I'm going to show a slide now that I ought to believe in and I want to believe in. So help me to believe in it. It's an American slide and it comes from the Commonwealth Fund. It's a slide that our politicians are using all over the place, and this is what it looks like. What's the best healthcare system in the world? And you will see the column second from the right has a lot of number ones in it. I think UK model has a great opportunity to have pride in that. The column to the right of that I'm not going to touch on yet again, but you'll see down here replicated the healthcare cost per capita. But I'm going to deconstruct some of this in a moment because some of this worries me. First of all, the data are relatively up to date, but of course there are data that have been accumulated over the past 5 years. Quality of care, effective care, safe care, coordinated care, and patient-centered care all give very high rankings to the UK, as does access, timeliness of care, not quite so much, efficiency, equity, and healthy lives. That's the odd one out. And those other indicators I will come back to and examine in a little more detail. But I would suggest to you that one of the challenges that we have is a healthcare system that's satisfying one set of indicators, but isn't yet reaching a perhaps more vital set of indicators. So let me go through the good news. This is what patients think of the National Health System. And again, this is a Commonwealth Fund recently published survey. And what is noteworthy is the extraordinary way in which the curves suddenly go upwards. There's a funding explanation for that. Through the Blair government period of 1997 onwards, there was a decision to put a significant additional investment into the National Health Service and to reduce some of the obstructions to access that had previously prevailed. One of them was a great delay in the gap between being referred for treatment and being actually treated. So instead of 18 months, it was reduced to 18 weeks, dramatically and quickly, and the patient satisfaction has soared. So the system view of patients was that the system works well with only minor changes needed, and a jump from 26% of opinion up to 62% of opinion, etc. Let me just then put that into a comparative context, which with the next slide. The next slide is about electronic medical records. Again, the figure for the UK, which is 97%, should be 100% now. So in primary care, which is the universal model across the country, all physicians are using electronic medical records. In secondary care, by the way, where we have some of the smartest hospitals in the world, about 30% are using electronic medical records. So there's a disjuncture. And actually, to me, it's a really curious disjunction that that part of the system into which we've pumped most of our investment for the past 2 decades is the least developed in terms of electronic medical records. I want to come back later to demonstrate what we could do with a wholly EMR system, but at the moment that's a serious outlier. But let me look at some of the other comparators. What do our primary care physicians report regarding the waiting periods? As a consequence of that significant increase in investment, waiting periods have fallen. And again, it's quite surprising if you compare it with 2 other systems that we previously saw were cheap systems, in other words, Australia and New Zealand, that waiting times are much longer there and waiting times have been brought down in the UK. Sometimes I feel we press on one bit of this great jelly called the NHS, and it sort of improves there but slides over into another bit of the, I was about to say structure, but that's the wrong word. So what do sicker adults think? So sicker adults and primary care physicians. On the left-hand side of the slide, what do sicker adults think about getting after-hours care without going to the emergency room? And it's really quite dramatic. There's a very high approval rate about the difficulty for getting to the after-hours care in the UK by comparison with the other nations. And doctors are reporting that they've got arrangements for patients to get after-hours care. Now, I report this with a straight face and with a seriousness of purpose, but often it doesn't feel that that's telling the real story as patients experience our services. Our increase of patients going to the emergency room is continuing to go up by 3% per annum compound. And a number of patients are sidestepping primary care and going straight to the emergency room as their model of primary care. So the slide now is again just simply a US-UK comparison in which you can see various indicators, access problems, arrangements for after-hours care, use nurses, case managers for patients with serious chronic conditions, electronic medical records, and routinely reviewing data on patient outcomes. All of them important measures, but none of them actually yet completely right. I want then to turn to something that worries me rather more. This was picked up in the bottom corner of the slide that I showed earlier, which compared several healthcare systems. But in terms of mortality amenable to healthcare, we see in deaths per 100,000 population that the UK is actually one of the leaders during both periods, during the former period, 1997 to 98, and during the period 2006 to 2007. We're behind the US in the latter period, but we're ahead of the US in avoidable mortality in the earlier period. That US-UK comparison worries me less than the comparison with France, Austria, Netherlands, etc. Now, the way of looking at this, I think, was best put by the Lancet in 2012, and I've put onto this slide a summary of some underlying issues with the National Health Service. What the Lancet did was to do a multi-nation comparative study. They took the 15 original nations of the EU, and they added Norway, Australia, and Canada. And then they looked at performance over 2 decades, from 1990 to 2010. The first thing to note, by the way, is a significant improvement in overall population health during those 2 decades, right across the piece. It's the unsung success of health systems across these developed nations. But for the UK, they noted, persistently and significantly below the mean of EU 15 plus in 1990 and worsening. So if we move away from input measures such as accessibility to GPs and after hours and electronic medical records and start to look what's actually happening in terms of outcomes, the story is quite a more difficult one. Premature mortality from several major causes, including cardiovascular diseases and cancers, are significantly worse in the UK than they are in the other EU countries. And there is a growing burden, as there is everywhere, but there's a growing burden, particularly in the UK, of disability, particularly from mental disorders, substance abuse and misuse, musculoskeletal disorders, and falls, particularly with an elderly population. So, let me pause at that point. I've deliberately tried to run past you some slides which demonstrate what a wonderful system the NHS is, but also, actually, that it is not performing at the level we would wish it to. I'm now going to move into what is the current environment and what is the relationship between the way in which the NHS operates and the way in which the political environment operates. And I'm going to do it, first of all, by showing you a slide which indicates how much interest the politicians take in the NHS when they're thinking about doing a major reorganisation. So, this takes us from 1990 through to 2012, and each one of these has been a major step. That model that I mentioned before of Nye Bevan of the Tredegar bedpan has ended up with a nationalised industry in which the Secretary of State for Health virtually has had the power to determine what the NHS is and to set its strategies and objectives and priorities. That works really well if we have the same Secretary of State for Health since 1948. Sadly, that has not been possible, and the turnover rate is roughly every 2 years, a new Secretary of State. Now, let me say once for all, they have all been utterly brilliant people, trustworthy, reliable, and highly intelligent and articulate, and I'm serious, many of them have been utterly passionate about the service. One thing they are not passionate about is what their predecessor did, especially if they're from the same political party, because that predecessor may be a rival for further advancement in the party. So the disruption that occurs from these changes means that the stability that we need over time to plan for better health outcomes tends to get frittered away on short-term changes in structures. And so it has been. I'm not going to take you through it in detail, but in 1990 there was the introduction of a so-called internal market. So instead of block grants going to hospitals, what happened was that the market was split between hospitals and GPs who are providers of healthcare and those who commission the healthcare, and they enter into contracts in a feeling of internal competition. I won't take you through all of that, except to say that the internal market thrived under the Conservative government until 1997. A Labour government came in, abolished it, but then 3 years later reinstated it. A Conservative government came in 2012 on a pledge that there would be no top-down reorganisation of the NHS, and then proceeded to do a top-down reorganisation of the NHS. And I'll explain to you in a moment what that means. But let me just give another introduction into who does what, because it's often a complex system. I'm not going to go into great detail, I can assure you, because eyes will glaze over. But we have a model of universal primary care in which every citizen is entitled to register with a primary care provision, with a GP. So we have 35,000 GPs. By the way, I'm now talking only about England. I'm happy to say my remit does not extend to Wales or to Scotland. And Scotland is still with us at the moment. But the model is, and I'll just explain the funding, so that for every citizen who's registered with a general practice, that general practice gets a fixed sum of money from us. The fixed sum of money varies according to demographic variables, as you would expect, but it's a fixed sum of money. And that means it's what we call a capitated model. The GPs also will get additional funding from us for meeting certain targets around the improvement of quality of what they do. We also fund dentistry, optometry, and community pharmacy. And then we have so-called secondary care, mainly the hospital sector. We've got 250 trusts running hospitals, particularly acute hospitals, but actually there are hundreds of hospitals, because each of these trusts will have responsibility, usually for more than one. Some are semi-autonomous and some have an economic regulator. Tertiary, quaternary care, highly specialised care is provided in a smaller number of hospitals. And then social care, just as in this country, we have a real dysfunctional gap between healthcare and social care. It is provided by local governments under a different funding model. Social care is paid for when it comes to residential social care. Health care is not. And these quite opposite funding models drive human behavior inevitably in quite dysfunctional ways. So much for the providers, and then briefly for the commissioners. The answer here simply is there is a single payer. One payer meets all the healthcare costs. And I've been fortunate over the past couple of days to look at some hospital experiences and look at some primary care models in the US. And the complexity of payer leaves me quite confused. And as I know, it leaves many of the providers quite confused. So this, by the way, is not the universal answer, but a single payer does simplify things quite considerably. So before the 2013 reforms, we had all of these bodies, and the top-down reorganization, which didn't occur, abolished them, 161 of them, and then created 212 new ones. And my happy job is chairing the top one, NHS England. So a couple of sentences about NHS England. It was a genuine attempt by the government to throw the Tredegar bedpan out the Whitehall window. A genuine attempt by the government to shift the entire budget for the National Health Service away from the Whitehall Department and into an independent board chaired by me. Yes, we're appointed by the Secretary of State and the Prime Minister, but the board is non-political and genuinely independent. And to us is assigned the entire budget. That's currently approaching £100 billion of public expenditure. We allocate, and I'll show in a moment how we do it, that funding across the country to a number of clinical commissioning groups, which are led by physicians to buy healthcare, to plan the healthcare needs of their communities, and to buy healthcare for those communities. And then there are other bodies. There's a body that regulates quality, which does inspections of hospitals and care homes. There's one that is an economic regulator, and then public health and health education are done by other bodies. Let me just explain, if I could just sum up what that means. It means we've got a single service, but we've got a hugely fragmented system, hugely fragmented. And our responsibility as the key payer, as the body charged with the complete budget, is to try to ensure that that fragmentation isn't visited on patients, as it too readily is, but the fragmentation is pulled together and made to work for the benefit of patients. Very briefly, how the money flows. The Treasury gives the money to the Department of Health. It gives us, these figures are out of date by a couple of years, to us. And we provide the nationally commissioned services, and we allocate a significant chunk to the clinical commissioning groups. So while I'm on money, I'm going to ask, well, what's happened to it? The answer is that the global financial crisis has visited the NHS very harshly. The consequence has been a 4-year squeeze since 2010, which is the greatest and longest period of austerity that the service has ever known. Now, when I say 4-year squeeze, I mean a settlement in 2010 with the new government which ring-fenced the NHS, which is the language that's commonly used. But ring-fencing the NHS means giving just above inflation increases year on year to the NHS. But the level of demand is growing and is being exacerbated. So two major drivers. One is actually population increase. Population's gone up by 300,000 over that time. So the consequence is that there has been a 5% reduction per capita in real terms over that time. Secondly, all of the features that are known in this country, an aging population, increasing price of drugs, medical equipment and everything else. And yet, and still to my astonishment, through those 4 years, we've delivered more operations, more attendances at emergency room, 6,000 additional patients seeing their GP, that's registered with their GP, more diagnostic tests, etc. Today, patient contacts in the NHS run at 1 million a day. The employment of the NHS is 1.3 million people. It's an extraordinary enterprise, and an extraordinary enterprise of people really dedicated to doing the best by their patients. But we have a problem for the future. So let me turn to our options for the next 5 years. The first one is a very favoured British model of governance. Actually, we're a quiet and reserved nation, but quite disputatious when it needs to be. And it may have been observed, I think, by those involved in healthcare that there are sometimes vested interests in healthcare models. And occasionally this makes it difficult to move to do the right thing, as opposing to doing the comfortable thing. So we have a real challenge, and it goes like this. We've had 4 years of financial austerity. The gap in the national finances has not improved. I mean, Britain's economic success story has been a huge increase in employment. So our unemployment level is almost down now to full employment. But the new jobs have not created new income. There is no new tax income because many of the new jobs are part-time or low pay. So the national exchequer remains unaffected by the growth in economic activity and will continue to do so. Secondly, one of the reasons we've managed to do reasonably well over the last 4 years is that we've held down pay. And pay is 60% of what we do, and if you hold down pay, then that counts in billions in terms of the total enterprise. Politically, that was possible for a period because private sector pay had taken a deep dive following the global financial crisis. Public sector pay had not. However, the curves have now crossed again. And so we know that we can't hold down pay. It's unfair to the professional staff, and it won't last for much longer. Thirdly, we've got a general election in May next year in which the NHS is now the top political issue and the manifestos of all the political parties. Now, this is extraordinary to anybody who doesn't understand the sort of visceral sense that the NHS has and the grip that it has on the population of England. If you saw the opening ceremony of the Olympic Games, you would have been, I think, utterly bemused. Why were patients lying in beds during the opening ceremony of the Olympic Games? Well, that was reinforcing the sort of sense of social solidarity that the NHS raises in people's imaginations. The political battle which goes on is often some distance from the reality of care. All of the political parties have indicated that they would ring-fence future funding for the NHS. Some of them indicated that they would put more resources in, but the resources are put in promises which have a symbolic resonance. For example, 8,000 more GPs, 10,000 more nurses. When actually what we need is a question, is it actually that manpower issue, or is it how we use the resources we've got at the moment? We know that we can make things run more efficiently, but pure efficiency isn't the measure. How do we make things work better for patients with a changing burden of disease, a changing patient population, and a need to concentrate on what are the new challenges that are coming through? As Chris said, we will be later this week publishing for the first time by the NHS, first time ever, a vision of our future. And we're taking advantage of our political independence to do that, and we're doing it with other major bodies. We've aligned ourselves with the major charitable foundations to try and understand how we can do things better. There's some nervousness in the government that we're taking such an impudent line. And that means that I can't spell out for you tonight the details of what it involves. However, what we will be identifying, I think, when the report comes out, are these three really critical gaps. The health and well-being gap. How do we cope with a population whose patterns of disease are changing? We now know that long-term conditions with an aging population are taking up 70% of our budget. And with longevity continuing to rise, which, by the way, is an excellent thing. Looking around this room, I think there'll be general agreement with that. But we see these really major tsunamis coming towards us. One is not just aging, but aging with the onset of dementias, which didn't occur with such intensity when populations did not age so far. We don't yet understand fully what dementias are, including Alzheimer's, nor do we have a magic cure for them. So we're anticipating that dementia is a major challenge for us for the next 5 to 10 years. Obesity and the associated disabilities that come from it, including type 2 diabetes, we're currently spending, we think, about £10 billion a year on diabetes and on its consequences. And we know that that will double by 2030 unless we get it much more under control, and that we need to be much more upstream in dealing with it. The second area is care and quality. Again, with an aging population, but not uniquely, we have had real problems of providing care for vulnerable people. Absolute scandals of hospitals where people have been left without proper nutrition, without access to water, left in bed sheets that are covered in fecal matter and urine, and neglected by staff to the point of cruelty, with absolute, quite shocking major scandals. So care and quality are high priorities for an improvement of what we need to do. And then funding and efficiency. The funding figures that I've mentioned to you add up if we add on the traditional increase in funding per annum to the NHS, which has been in the region of between 4 and 5% per annum. And if we simply project that forward to 2020, you could see a gap of £30 billion per annum in the budget for the NHS. It's quite easy to get to that figure, by the way, and it's quite shocking because there's no way in which the National Exchequer is going to be able to meet that funding gap. There are two consequences from this. The first is that every additional pound of investment that goes into the National Health Service with a stagnant economy comes out of something else. Absent increase in tax, and there is no political party going to the election promising to increase tax, except for a mansion tax, which the Labour Party would introduce on mansions, which are defined as properties worth £2 million or more. Actually, they're mainly apartments in London. They're not mansions, so some have interpreted it as a London tax. But the only other course is to take money from other public services. And so the consequence, and it's a serious one, is that money is taken from schools, from universities, from public libraries, other public services across the board in order to prop up an ailing NHS. So we know that that is not socially acceptable, that's not publicly acceptable, and the NHS is going to have to reduce, it's going to have to learn to live with lower income, but not do what started to happen in France and in Australia and elsewhere, which is that the offer to the public is reduced, the quality of services declines, or co-payment is introduced. The only co-payment we have is for pharmaceutical prescriptions and for some dentistry and optometry. The rest is free at the point of need. And no party, by the way, is going to the country next May to offer them the opportunity to pay for their health care at point of use. So the way in which we need to organise it, we understand, needs to focus much more now on real prevention. We've spoken about prevention for decades, and actually we've done very little about it. So we will be committing ourselves to some major steps around prevention and public health, bending the so-called curve on demand. Look at these figures. 20% of the adult population still smoking. It's higher than it is in the US. And of course, there is a sharp socioeconomic correlation. We know that if I just take one population group, pregnant women, if you look at two local areas, one is Kensington and Chelsea in London, the proportion of pregnant women who smoke is about 1%. If we go to Blackpool, up on the east coast, up on the west coast, the proportion of pregnant women smoking there is 28%. It's absolutely stark. And that indicates that public information campaigns and, as it were, the social unacceptability of smoking in public places are not enough in themselves. We're having to deal with a sharp socio-economic divide. 1/3 of people drink too much alcohol. Well, too much is always a bit difficult to define, so I'll move on quickly. 1/3 of men and a half of women don't get enough exercise. Well, likewise. But more seriously here, We are trying now to start to work with local governments and with cities. The Mayor of London, Boris Johnson, published a report last week about how do we make London a health city? How do we make London a place where people walk and cycle rather than take public transport or use the motor car? How do we get people out onto the streets? How do we get people taking exercise and reducing overweight? Do you know where we will start? It's with that group that I mentioned to you before, the 1.3 million people who work for the National Health Service. If we as employers can start to work with our own employees and provide inducements and incentives, it's quite simple things. If you go into some of our hospitals, what's served in the cafeteria is chips and hamburgers and carbs and sugar piled up on plates. So I can tell you culturally, that's quite difficult to change, but change it has to. We need to start with our own population and to provide real incentives, not shame, not embarrassment, but real incentives to people to understand why a healthy lifestyle might help them. And that figure of 2/3 of the population overweight or obese is really scary. We are now the fattest country in Europe. We still, I think, defer to the US in terms of global rankings, but in Europe, it's embarrassing. And actually, the trend seems to be consistently upwards. School children, by the time that last box is not exactly right. We know that by children go into school, about 1/5 of them are obese, and by the time they get to year 6, that's gone up to 40%. So we do need to start with children and with homes and with family lives. So I've put in there a number of things which I'm not going to spend time on because I want to ask us, what can the NHS do to start wrapping care more effectively around patients? Many of the issues that we face are very common to those which are faced here. One of them is a model of primary care which is based upon a 1948 assumption of the nature of disease. And a big difference, in other words, a population which would not go and see a doctor unless there was something wrong and something that they were worried about. In fact, Nye Bevan forecast in 1948 that although the National Health Service would cost £500 million, which was under 1% of GDP, it was a huge amount of money, it would fall away by 1951 because everybody would have been patched up and they would have had new teeth, hearing aids, etc. And after that, the NHS would be a low-level spend. Well, of course, it's not at all accurate, but the outcome and the inheritance from 1948 has been a very mixed model of primary care. Our primary care physicians, if you like, the community generalists, are self-employed. So each primary care practice, and I showed you before there are 8,000 of them, is a company, it's a partnership. We pay the partnership those sums of money for the patients, and the partners distribute the money according to the need of the practice, and then the profit at the end of the year is the partner's income. It's not a model entirely designed to ensure that as much investment goes to the patients as opposed to the partners. The model also falters in several respects in that there are many GP practices that are still just one GP. Now, in 1948, that was fine. In 2014, it makes less and less sense, given the complexity of medical knowledge and the demands for high-quality diagnosis that we impose upon primary care, if it's to have any function at all. In London, 20% of general practices are single-handed, 40% are single-handed or double-handed. So we know that we need significant reform. Oddly enough, in London, there is one practice where, although there are only 3 partners who own it, there are 110 doctors run by those 3 partners, giving a comprehensive medical system across South London. So what we are proposing, and these ideas are not new, but to actually bring them together, I think, has been tremendously important for us, is a new model of enhanced primary care. What we will do, and if you move to the right-hand column, the delivery model will be multi-specialty groups, rather like I had the privilege yesterday in Boston of visiting the Chelsea Medical Center associated with Massachusetts General Hospital and also the one at Revere, which are really good models for what we're trying to do. We are willing to learn from any system in the world that can demonstrate high quality care for patients. But not only will we have these systems that employ generalists, the GPs, but we want to break down the barriers between specialists and generalists, and those who work in hospitals and those who work in primary care, and those who work out in social care in the community, and the pharmacists and the nurses. So the new model would be one in which GPs would hire specialists. So this is already occurring. It would not be uncommon now for a diabetologist, for example, based in a hospital, to reduce their contractual commitment in the hospital and sell their services to a primary care centre such as this, so that patients can come into primary care and receive the treatment that obviates any need for them to go to hospital. If we can cut down on hospital admissions, which is the most expensive care environment, and bring more care into the community, more care and intervention upstream, and to prevent the diseases that are causing hospital admissions, we know that we can make it better for patients. We're going to also propose reviving smaller hospitals. We've had something of a belief system that small hospitals are bad, because you can't obviously staff every hospital to the same level as a world-class institution. But we don't believe that should be the mission of a small hospital. We would like to see smaller hospitals run by GPs, the GPs having admission rights, but combining it with these multi-specialty groups so that patients can have both care, rest care in small hospitals, but also they can become focal points for where we can provide an array of treatments closer to home. Chemotherapy, for example, doesn't have to be in a high-cost, world-class hospital under glaring lights. Chemotherapy can be provided closer to home using experts, but in an environment that's less challenging and less difficult for patients. We're looking then also to see whether our hospitals, this is a bit like Massachusetts General, but why shouldn't our hospitals also run primary care? Why can't we get an integration between primary and secondary care so that you walk through the door of the hospital, primary care is there, if a referral is necessary, it's within the same system, possibly even within the same building, possibly even a capacity to call a consultant down to the GP's consulting room and get things sorted out there. Our dysfunctionality at the moment would often mean that an elderly person seeing a GP will be referred for complaint A to specialist B, and for complaint, I'm going to get my numbers confused, but you know what I mean. Four specialists, 4 different complaints, 4 different waiting rooms, 4 different outpatient clinics, 4 different prescriptions, and 4 medical records lost. And the GP having no idea what's going on. So we need a much more joined up and less dysfunctional model of care. And as we roll out electronic medical records, that will help on that. And this then leads us to the accountable care organizational model. Now, what's the difference between that and what I've just been talking about? The difference is that at the moment, most of our hospitals earn their income by their activity. So we would perhaps contract with a hospital to do 500 hip operations a year, and then there's a national tariff for what they're allowed to charge, and they get paid for each one. What we are suggesting is that for the future, and particularly for segmented patient groups, perhaps patients over 65 or over 70 or over 75, there is a single sum of money agreed between the provider and the commissioner, and everything is wrapped up in that. And risk is shared, but risk is shared in a different way. We've looked at models such as ChenMed in Florida, which we think is a really interesting model that could be adopted in the UK. And our job as the banker for all of this is just to try to ensure that we don't put barriers in the way of these radical changes, that we lift the indicators, we lift the funding lines, and we lift the regulations that separate primary and secondary care, that separate specialists and primary care physicians. And then if we invert that last model, the next model is one in which primary care has a right or the ability to admit patients to hospital and look after them in hospital and to coordinate the care of the specialists in hospital. The final part of this will be, I think, a reduction in the number of centres doing the highly specialised work. So the Massachusetts General Hospital model, which we have variants of in the UK, will be reduced from their present high concentration to a relatively few number. One of the indicators for that is how we treat stroke in London. Up until 3 years ago, patients suffering a stroke in London would be taken to the nearest hospital, of which there are 32. We could look at the outcomes of that and see huge variations of outcomes. And we realized that there were some units that were receiving more stroke victims, and with greater experience and technology and staff were treating them more successfully. So, and I won't go through the struggles that then ensued with the clinicians, but we got to the point where we declared that we would fund 8 stroke units. Ambulances were instructed to drive past all other hospitals until they, that, by the way, was the critical thing, until they got to one of the 8 hospitals. And we can now demonstrate lives saved, about 250 a year. Quality years added to lives that have been saved, inestimable. The data are there. And these are not rocket science. These are just ways of changing the basic model of care in a way which wraps the care around the patients and is at the highest quality internationally, rather than spreading care out indiscriminately amongst many hospitals. I want then just to look at 2 final issues. The one is how we will cope with an NHS which operates at scale and across a whole population in an era of personalised care. Because we can all understand that the for example, for the pharmaceutical industry, the blockbuster pipeline is broken. Drugs in the future will be fashioned much more around individuals, and care will be much more a function of empowered individuals determining their own future in consultation with the clinicians. I pay particular tribute again to Al Mully, who has led thinking globally about how clinicians need to interact in a different way with patients, to listen to what patients are saying, and to provide the care that patients choose from the menu of options, as opposed to the care that the clinicians prefer to provide, often on the basis of limited evidence as to quality of outcomes. I'm not going to go into all of this in great detail, but we are investing heavily in technology. By 2018, all medical records will be electronic and will be completely interoperable between all providers of healthcare. That's a fundamental commitment. It's, by the way, one that we made in 2002 and failed to deliver on then, but forget that, that's politics. I think we've got it now. We've got it that you don't do IT by buying huge systems and trying to do a whole country of 55 million people. You do IT by allowing systems to be brought to a standard specification and with interoperability, and with every patient having a unique identifier, which for us is easy, that every patient has a National Health Service number, and the UPI is therefore universally applicable. I'm not going to look at these other issues because we are going to otherwise run too close to time. I do, however, want to look at personalised medicine as well as personalised care, because this is something that I'm really struggling with, both as chair of the NHS England, but also as a former president of a fantastic scientifically oriented university. I just put in one boast, actually, for that UCL. 2 weeks ago, we got a Nobel Prize. The Nobel Prize for Medicine went to John O'Keefe, who joined UCL in 1967, just to indicate how long it takes to get there. And today there's a story coming out, I think it may be in the US press tomorrow, about another colleague of mine at UCL who has worked for 40 years on stem cells and has now found a way of joining up spinal cord. So he's done a spinal cord repair on an initial patient, and that patient is now being photographed walking. Not unaided, but walking with support. And it's an extraordinary breakthrough. Okay, it's the first patient. There's an enormous amount of proof yet to be done, but it's the first in man. He's done it previously with rats, but it's the first in man, an extraordinary achievement. And I mention both of these to underline what we've got is a real opportunity and a challenge. How does England exploit this exceptional science base and technology base to do two things? One is to benefit our patients, and the other is to develop an export market which can help to sustain the funding for the NHS in the future. So we are introducing a project to sequence 100,000 human genomes. And this is now underway. We've commissioned the sequencing contract. Illumina, a US firm, is investing in the UK and will undertake the sequencing then. We're concentrating on rare genetic diseases, which makes an awful lot of sense. And if you do these over a population of 100,000, you can start to see correlations that are not visible with small batches. We're looking at cancers, and particularly cancers where there's already been discovered to be a strong genetic indicator, mutations that correlate with certain cancers. And we're also looking at infectious diseases. It's an extraordinary effort because 100,000 would have cost us actually £1 billion just 3 years ago. And the way in which cost has now come down means that we can bring it within budget, and it will be ultimately about £300 million. But what is much more important is mapping phenotypic data, the patient's data, onto the genotype, so that we can properly read the sequence against the phenotypic data. And even, I think, more profound, having with patients' consent taken tissue samples that can be used for the next wave, which is around future proteomics and metabolomics. Interposed into all of this is a major clinical interpretation exercise because we have to understand what these data mean and do two things. One is, are there benefits to this particular patient in reading back and using these data to affect their treatment, which is actually, I think, going to be unusual rather than common. But what does it mean for a whole population once we can start reading 100,000? We know, I think, from there that the next sample is probably going to be 500,000 or more. I don't anticipate that we will sequence the entire population because we're not doing this for universal coverage, unlike the rest of the NHS. We're doing it actually in order to understand where genotyping can take us in terms of understanding disease. Big data is the final area. Can anybody possibly conceive of a health system that is not transformed by big data in the next 10 years? I really worry, if I put it another way, at the moment I think we're denying our patients the transformative benefits that we've all experienced in every other walk of life through technological change and increasingly the use of big data. And my guess with the NHS is unless we're upfront, unless we're embracing it, unless we're leading it, unless we're driving it, in 10 years we'll be buying our patients' data from Apple and from Google. Because there's an enormous amount of investment pouring into this space. So we're determined to try and get the NHS positioned as one of the global leaders and awoken from what is often, I think, an issue with the NHS of being inward-looking, slow to adapt, and not being globally perceptive in how it needs to change. So we can see, I think, a remarkable new vision for medicine and care for the 21st century, using all of these things. And when I say all of them, I have to say each one of those options that I've outlined to you is an enormous amount of work. An enormous amount of work to secure safety to patients while we move to new models of care. But much more than that, the work involved in cultural change, in taking our employees with us, and taking clinical communities with us, and getting everybody back around to these simple propositions. Healthcare system, free at the point of need and sustainable within a reasonable cost. A focus on providing high quality care, but knowing that the more you save on this patient, the more you can spread the benefits across other patients. And the, I think, final question is being able to continue a health service with which the British population have invested and wish to continue very strongly to invest for the future. It is an impossible challenge. But when I started the job, people said to me, you mustn't talk about problems. Or wherever you go on a public platform, don't mention problems. So I said, okay, well, challenges. And they said, no. You're not to talk about challenges. It's the wrong language. It's very negative. They said, you've got to talk about opportunities. So tonight I'm drowning in opportunities. Thank you very much for your attention. Excuse me.
Thank you very much. Professor Sir Malcolm Grant has graciously agreed to answer a few of your questions. We have 2 mics circulating the auditorium, so I ask 2 things of you. Once you've been recognized by him to ask your question, wait until we bring a microphone to you. I know it's going to be a brilliant question. We want to get it on the videotape, but we need the microphone to do that. So wait for the mic. And then second, please make your question a question.
Yes, there's a lady in the front row.
Thank you for coming. Is on?
I think Chris just has a strong voice.
Hello?
No.
Where's the other one? Let's try this one. Can you hear that?
No.
No. Are our mics not on at all?
You have a very strong voice.
I carry it. Projects.
Mic doesn't work.
Says that it's on. You not hear it?
No. Maybe they have to raise the volume.
Where's my tech guy? All right. Project your question.
Thank you. And in America, we're really, really proud of our medical system. Other than being able to deliver the most sophisticated surgeries to a few people for a lot of money, is there anything that we do well here compared to other developed countries?
Yes, I mean, I think, yes. Shall I repeat the question? I'm not sure whether... The question was, is there anything we do well in America in healthcare compared to other countries, apart from highly specialized surgery? Yes, I think there is. But I think the criticism that is widely expressed about the US system is the gap. And the rest of the world watched Obamacare with rising concentration. It wasn't just the web page breaking down, but it's the question which Europe certainly gets, which is that you have an obligation to provide a healthcare system which people can access readily and at reasonable cost, even if it's not free. I've been very impressed, though. Of course, I went around Massachusetts General Hospital, which is the epitome of the high cost, high quality, brilliant healthcare, proton beam therapy, exceptional cost, but great results. But I also went around, some primary care models, which I thought were very, very good, and from which we could learn. So I think there's stuff that's done very well in this country. What I worry about are the health inequities. And every country has an inequity of health, an inequity of access, an inequity of treatment, an inequity of outcomes. And a deterrence from cost is one of those major inequities. Shall I take another question? There's one in the front.
Yeah, let's try this. Oh, did you hear that?
Yeah.
That's working.
Thank you for a very interesting talk. I'd be interested to hear, you mentioned briefly that general practitioners are given a certain amount of money for for providing quality in certain areas. So I'd be interested to hear what those are and if you'd like to see those payments change at all.
Right, it's something called the Quality Outcomes Framework, and what we do is provide a proportion of income to each GP practice for certain items that they've done. So, for example, it might be immunization for under fives, or it might be a checkup on diabetics or some other disease group. And there's quite an argument about this. There are 2 problems with it. One is, why aren't they doing it anyway? And why should we pay extra money? And the second thing is, well, it's so complicated. I mean, there's a lot of form filling and detail that has to be done that consumes the time actually of qualified medical practitioners, because they're the ones who have to be able to fill in the form. So I think we need to keep it, but continue to refine it and to have a greater expectation, particularly of these larger medical centres, that they're doing all of this stuff. And we'll specify that in the capitation agreement. And but in the interim, it's been really successful in pushing up what GPs do and broadening more of the, shall we say, monitoring and prevention part of their work. Yes, the lady over there. Sorry, I'm not paying attention.
So in the US, a lot of our debate is focused on how to balance provision of healthcare with individual responsibility, both for health maintenance behaviors and for appropriate use of healthcare. And we do that through a lot of financial incentives. So I'm wondering, in the UK, how you conceptualize of that individual responsibility and how you do incentivize it without monetary changes.
Yes, it's a big area for us because there is a lot of irresponsibility in accessing healthcare. A lot of people go and see a primary care physician or go to the emergency room when there's absolutely nothing to justify it. I mean, there's a lack of confidence. People, particularly with young children, it's a way of reducing risk, and they'll go and seek advice. The areas where, and by the way, when it's all free, there's no financial barrier to people doing it. And that's a constant argument for us. But the way, and I've not had time this afternoon, we are looking at a model called integrated personal commissioning, in which we will do with some groups, say particularly people with learning difficulties or elderly population, is to say, here's your budget, you spend it. So we give them the basic care that we've got already. But if they've got a budget, let's say, I don't know, $4,000 or $5,000 a year, and they're told, you can spend that on travel, you could spend that on getting a wheelchair, you could spend it on going and getting physiotherapy treatment or whatever. You choose. It's your budget. And we do to empower people, rather than have a team of scribes filling in forms and saying, yes, this patient qualifies for physiotherapy. And I think this will be truly empowering and actually will reduce our cost. And I'm sorry I didn't have time to go further into that earlier, but it's a powerful model. It's so powerful that already the British Medical Association has come out against it. So that's an indication of its potential power. There's a hand right up the back, and then I'll come back to that side.
So my question is maybe not directly related to healthcare in countries such as the UK and the US. I'm actually involved with a global health nonprofit. So I was just wondering, based on your experience, if you've seen, if you can just talk a little bit about like some of the ways that underdeveloped communities which lack healthcare some of the ways they can come up with to fund their healthcare systems, and secondly, what kind of a role Western nonprofits can play in helping them develop those systems.
Yes, that's a really good question, and of course, it's wrong to generalize because all of those nations have quite different cultures and quite different healthcare systems already in place, if they have one. But there are various models. I think if we take India, I'm told that 90% of the investment in healthcare goes on 10% of the population. There are some world-class outstanding hospitals in India, the Apollo Group, the Max Group. But what they also do is take in non-paying patients and cross-subsidize them from high-paying patients. So that's actually a very good model. But it's rather like a tax system, in which high taxpayers subsidize low taxpayers or non-taxpayers. But the problem is it's still too fragmented, it's still too small and as a proportion of total population. So just continuing with India, we're starting to see, I think, the impact of new technologies. And I think a number of places like India, which now have high penetration of mobile phone and low running costs, have a capacity to do things that we still haven't mastered in the UK and the US. Telehealth, telemedicine, and being able to communicate even from very remote rural areas where there's no qualified medical practitioner, but to a medical center where advice can be given. China, I think, may go in a different way, and Al Mali knows much more about that. I think we may see some American hospitals establishing themselves in China. But rather more interesting, I think, is where in the old days you might have had what was the barefoot doctor, in other words, the qualified or not qualified physician, but who lived in the community and operated frugally. I think the modern model is the iPad doctor, again, using technology as a way of getting advice to individuals in a society where modern medicine is going to take a long time to spread. The Chinese government has committed to training 100,000, 450,000 GPs. But that takes a while, even in China. And in the meantime, there are serious structural issues in the provision of healthcare in China, particularly low pay for health professionals. And as we know, therefore, a sort of arbitrage over the supply of drugs and the involvement of global drug companies in almost complicit in a black market in drugs to subsidize the health professionals. But I've just identified two countries. If you look across Africa, you see some nations like Rwanda are changing dramatically, and others where change will take a long time to come. I think the common theme I would bear in mind is that there is no need for those countries to replicate the way in which we do it here, either in this country or in the UK. There's an opportunity to be quite radical in the use of technologies for a different model of healthcare. Sorry, there's the lady there and then the gentleman in the middle.
Hi. So going back to payment structures, less with, like, say, physician groups or hospitals within the UK. I think one of the major benefits of being a single-payer system is the ability to negotiate prices for pharmaceuticals or devices based on sort of a common understanding of what's worth it and what's not, cost per quality, the evaluations that NICE does. How much of that savings would you say, or I guess how much of like the more efficient care given in the UK versus say somewhere like the US would you attribute to sort of that savings or those evaluations? You were saying like 60% of the cost is salaries, but what makes up the other 40%?
Oh, well, the drugs bill, out of our 100-odd billion, the drugs bill is about 12 to 13 billion, sorry for the rough estimate. And about 90% of drugs are prescribed in primary care, but we have a very high use of generics. So the UK is way ahead of the rest of Europe in the proportion of drugs used that are generics and low cost. And being a single payer allows us to insist upon the use of generics. At the other end of the scale, of course, are the very high-cost drugs, particularly in cancer, and that's where we have a constant battle. So we have agreed a deal with the pharmaceutical industry that they will cap their prices for 3 years. Partly this is an attempt to, they cap our total drugs bill for 3 years, is what I meant to say. And what that does is they hope to encourage clinicians to substitute new drugs for old drugs if that's price neutral. But beyond that, we have a real problem with cancer drugs because the government introduced something called a Cancer Drugs Fund, which bypasses the usual processes of approval. And although we set a budget of 200 million, it rapidly grew to 400, just because if you lift any control over price, and the pharmaceutical companies can charge what they want, and the doctors can use it, then we've lost it. So we're I wouldn't say suppressing that, but we are gradually shutting it down and bringing it back into a formal approval process. The answer to your question, I would say, is that NICE, which is the National Institute for Clinical Excellence, which gives advice to the NHS on what drugs it may use and what it may not, according to their clinical effectiveness versus their price, has saved us billions of pounds. And actually without detriment to patient treatment. I did promise the gentleman here, and then there's a lady up there.
Do I get both of them?
Your slide where you had the 5 blocks of major problems, including childhood obesity, adult obesity, smoking, failure to exercise. these are behavioral modification problems that lead to medical problems, but they aren't really medical problems. They're public health problems. There's no real need for a doctor, a higher-priced professional, to be involved in a lot of these modifications. And I notice on the right-hand side of some of the solutions, you opted for a more expanded use of personnel. So if you could envision optimizing the use of other practitioners, non-medical practitioners, to do a lot of this behavioral modification, what effect could that have on your total cost?
Well, this really is the magic bullet if we can get this. The problem historically is that we've tended to see public health over there and national health over here. And the National Health Service, it hasn't been a health service at all, it's been a disease-fixing service. So we wait for people to get ill, and then we do a transactional model of healthcare, and then we throw them out at the far end. They may then go back into the very modes of behavior that brought them in the first place. So it's quite a dysfunctional model. That doesn't mean that you have to use, highly qualified health professionals to do this. It's really complicated, but I think we need a much more national policy approach. One is over the pricing and sale of high sugar food and drinks. I rather admired what Mayor Bloomberg tried to do in New York, and I think we can probably start to get advocacy for such a program here. I think that it's wrong to blame, I think it's wrong to just go into a blame game and say it's the food industry. I think we actually need to show that consumer tastes can be changed and that a different approach to providing food and to its consumption can prevail and can help people. But that's just obesity. I mean, the other major correlation, causation is socioeconomic. The obesity rates with poor people are much higher than with rich people. And there's also an ethnicity issue. If we look at obesity across the world, there are ethnicity correlations with obesity, and actually even sharper ones with type 2 diabetes. But if the physician's going to succeed with bringing down type 2 diabetes and the other higher incidence conditions that follow from obesity, then we have to move it upstream. And we need, I think, advocacy from clinicians that this is what's needed. Our doctors won't say to a patient in front of them, "Have you thought about your weight?" And so many patients then say to us, "Well, the doctor hasn't mentioned it." It's a really sensitive conversation to have, and it's not to shame people. There's no shame in this, but it's just to explain how things could be changed over time. There's no magic cure, but I think physicians have a responsibility.
But getting at the question of ultimately the cost of the national public health system, if you shift a lot of those functions away from physician towards, in reality, lower paid positions with different skill set that's not necessarily medical, what effect could that have on the bottom line, the cost?
Well, that would be one of the points of the... Yeah, but that would be one of the points of those multi-specialty centres that I spoke of. But the cost of that is probably broadly neutral. The critical question is how do you bring down the incidence of type 2 diabetes in the first place? That could save us a fortune. I said earlier it's about 10 billion a year treating patients with type 2 diabetes, and that's growing. If we could crack that, and in particular the obesity, which has the totest correlation to it, then we could save a lot. And by the way, I wouldn't mind putting highly expensive professionals on it if they could do it.
Perhaps one more question?
I think it was the lady up there had her hand up earlier. Yes, right beside you.
Yeah, I was going to ask about getting after the food industry, but you did cover that. So I'll alter my question a little bit and ask if in the UK, do you find that the healthier food is much more expensive than the unhealthy food? Because here, you can get a McDonald's hamburger cheaper than you can get a head of lettuce. Yeah.
Well, actually, it's getting worse. We've tracked it recently, and the cost of unhealthy food, as you put it, has been actually falling while the cost of healthier food has been rising in an otherwise relatively stagnant economy. So the gap is getting greater. And I mean, experts much more knowledgeable than I am are scratching their heads as to, is there a model of food tax which would change behavior yet would not bear too heavily on disadvantaged communities? And that I think is a real challenge. But you know, a lot of this is also allied to other conditions, including mental health and depression. And it's a much more complex issue than headline writers often give it credit for. I think we've run out of time.
Yeah, wonderful.